very much Professor David Szpilman. That is, I think that the most important expert in the world about drowning, and I think that we are very lucky to have him here to do this presentation. So thank you very much, and I hope he will be useful. Thank you.
Thank you, guys.
So you can start when you want.
Okay. I was waiting for your call. So at any moment that, because I only can see you, Giorgio, and at any moment that stop talking or the internet fail, give me a heads up, okay? I hope everyone understand my English. I speak a very good Portuguese and well Spanish too. So whatever you have some doubts about what I am going to say, you just stand your hand, and I will stop and clarify anything we need. Okay. My background is I'm a general secretary of Brazilian Life Saving Society. I'm a colonel medical doctor from Fire Department of Rio de Janeiro. I always work at the beach since 30 years ago at pre-hospital attendance, at the helicopter and ambulance, making attendance for drowning stuff. So, and then I also was a head chief of the ICU of a great trauma hospital. So I was able to see the drowning patient at the beach until they get release or discharge of the hospital ICU. So I get all the view, all the open view from the very beginning to the very end point. So I was fortunate to have this moment. And I'm a coronel medical doctor of the Fire Department of Rio de Janeiro, retired. I work in the civil defense. I'm a co-founder of International Drowning Researchers Alliance, which I welcome you all to submit your membership. It's a free one, no payment. And I'm a medical and prevention member of the International Life Saving Federation. So I brought you a very simple case that can be an example of what really happens on drowning. And this is a pool where a 4-year-old girl was left alone. And we will discuss a few things about that situation. You see that she is drowning, and you will see by the time that she is still breathing water. Her heart is still beating, but you see that she is struggling to have your airways out of the water, but she is unable to do that. People, if you observe, you're gonna see people, you're gonna see a very small children here play in the pool that is for children. She was left at the big pool. This is an apartment building with a pool. You know, you understand there is no fence, and you're gonna see that how people are walking here and didn't see any drowning situation. You can see that, for example, this girl is unconscious, no response. and it was about 1 minute and a half, something like that. But she's still struggling. Movement is making, and people are passing here, and there's another one who will pass here also, and nobody pay attention to this girl. Was a situation in the north of Brazil 3 years ago, where the security camera had taken this footage. So you're gonna see now, the security guard coming from this side. And I know this is a struggling situation. It caused a lot of anxiety, a lot of pain to look at it, because she is already on respiratory arrest. Only the breathing is taking, and then suddenly the security guard can see the problem and had pulled her out of the water. So you see a lot of people getting around the pool, and nobody sees the drowning happen. So it's very important that when we look to the drowning, we can establish if it's a drowning or a swimming or a swimmer very comfortable. And how and why did it happen? Why a girl so early age was left alone in a pool that is very dangerous to her? Because people and parents and grown-up people seems to look at the pool and see there is no big risk for them. So they try to simulate that it's the same for this kind of age, and it's not. It's very dangerous. And how could it have been avoided? The pool should have a fence. The parents should look at that girl very carefully all the time. 100% of the attention should be given to this very young girl. And how to recognize a drowning is happening. You see, it's very often that someone looks at the water, and there is a lot of video on the internet that shows someone drowning just beside another one. And this one was unable to see that it's a drowning happens. So it's very important that you are training know how to recognize a drowning. We want the drowning hands up and say, "Oh, I'm in trouble. I want to help." But this is not what happens in real life. What happens in real life is that the person cannot extend his arm, because at the moment he tried to do that, he sink. And he tried to use whatever effort he has to stay floating. So what you will see is somebody that is struggling in the water, somebody that is making a lot of effort, but it doesn't move any meter. This is a drowning situation. And how to react to something like that? The reaction of the security guard was very simple, because it was a pool. The girl was very near the deck pool, so he can grab the arm and pull her over the pool. But it's not always like that. So we always try to help someone in the water without becoming a second victim. And how we do that? We throw some flotation. It can be a phone, it can be a surfboard, it can be a buoy, it can be many things that can flow. You can throw to the victim, and he or she can stay afloating. The important thing here is not to take the victim out of the water, but the airways out of the water. And you can help with that if you can throw some flotation. And how to remove from water. As soon as you understand there is someone drowning, you should ask someone to call for help and throw some flotation. And what really is safe to you as a rescuer is to wait for the call for help you made, for the professionals to arrive and make the rescue. You should not get in the water because the danger is very high. For example, in Brazil, we have 16 persons dying every day by drowning, and 2 of them die because try to help someone in the water. So it's very dangerous to get in the water. So when removing her from the water, the girl was in cardiopulmonary arrest. How do we carry out this initial assessment? So it's very important that you realize the ABC is better than CAB and or compression only. Does the submersion time matters? Yes, it does. It seems that this is the main factor to affect outcome on drowning. So for her case, it was very short. It was only 2 minutes and 35 seconds, which gives her a lot of possibility, a good outcome, if there is someone to start CPR on the side. Which is more important, BLS, basic life support, or advanced life support? We as medical doctors, emergencies, try to think that it's very important that advanced life support get on the place immediately. But if you don't have a basic life support giving immediately resuscitation to this victim, your arrival will be very short of chance to be successful. Actually, the successful of a resuscitation of a drowning person is 7 to 11% only. So it's very important that all of us know how to act, how to react to something like that. And one, not to start CPR at all. You get a call, you live in a condom, and everybody knows that you are a medical doctor. You are a pupil of Dr. Giorgio, and so everyone will call you, knock on your door, and say, "Oh, there is a drowning at the club. Can you help?" So it's very important for you guys to know how to help without becoming a second victim. So every cardiac arrest by drowning with evident signs of irreversible death, which is cadaveric rigidity, livor, and a body decomposition, or more than 1 hour submersion clocking, really matters. It doesn't matter to resuscitate or try to resuscitate. Is that, Giorgio, is that people are understanding me? Okay. So the next step, okay. The next steps, advanced life support arrive at the scene in 8 minutes, finding the drowning child still in cardiac arrest. When do I say stop? There is no more chance. We don't have to do any more cardiopulmonary resuscitation. At BLS, if you get return of spontaneous circulation, exhaustion, or if the ALS arrive, so you give it away. So there's only 3 possibilities to give up, to stop CPR when you decide to start. At the ALS standing point, you have to do 15 minutes of CPR and be sure that the body temperature are over 34 centigrades and the victim is still keeping a systole. So for that girl, CPR maneuvers were maintained, an orotracheal tube was introduced. It's very important to give oxygen, and the reason for the stop, the heart stop, is a lack of oxygen. So this victim is very important to always give oxygen. So an orotracheal tube is very important for her. A venous access was established and 1 milligrams of IV adrenaline was injected. The tympanic temperature was 33.5 and the rhythm on the monitor was a systole. So we should still going on until at least 34 of temperature. Tympanic temperature is the better way to deal in the emergency in pre-hospital attendance. I imagine in the emergency also you cannot use a thermometer on the axilla. CPR maneuver were maintained for another 10 minutes when circulation and heart rate returned. This was a grade 6, and she was taken to the hospital by the ambulance, and during that transportation, airway patency maintenance was still there, and ventilation along transporting with bag mask and reservoir with 100% oxygen. It may be too much, 100%, but still at the very start point, beginning, it's important that you keep the oxygen as best as you can. You see, pulse oximetry was over 91, and it's another very important thing is that this patient is always hypothermic. So a reliable use of pulse oximetry is important, and it's important then that you compare with the pulse, the arterial pulse, to make sure that you are capturing the real oximetry. Blood pressure is okay, circulation is maintained, peripheral access with saline was in line, sinus written on the ECG monitor, heating with thermal blanket, we need to warm her up. We need to take precautions to monitor and avoid a new cardiopulmonary arrest, which is usually common. In the emergency room, orotracheal tube was a good caliber, but beaten, and was semi-occlusive and selective to the right lung. So a Gadel was introduced, and a orotracheal tube withdraw 3 centimeters and reattach it. We began mechanical ventilation with tidal volume of 250, respiratory frequency of 16, admission pressure of 28, inspired fraction of O2 kept it at 100%, PEEP at 8 centimeters, which gave us a 98% of peripheral oxygen saturation. Blood pressure is a little low, and probably by the mechanical ventilation, which show us a little hypovolemia. and a large caliber of venous access and an increasing saline volume were performed. A nasogastric tube was inserted and fine air, water, and cornstarch. Urinary probe drained 350 ml of dark color, which is usual during the cardiopulmonary resuscitation. It's common to have hemoglobinuria, maybe some trauma when you pass the ring probe, and this is a usual thing. We request chest X-ray, arterial blue glasses, complete blue count, urea, creatinine, and blood glucose. The chest ray show this kind of acute edema pulmonary, which seems like a respiratory distress syndrome, and it's very similar, but this all goes away with the mechanical ventilation in 48 to 72 hours. So it's not really a distress syndrome, adult stress syndrome. The arterial gasometry was with metabolic acidosis and respiratory alkalosis. Blood count was with glucocytosis with the left shift, and this is usual. You imagine this is a trauma. She had been resuscitated, and this is a very common find. One of the biggest error we as an emergencist or intensive care professional do is to evaluate that, oh, there is a pneumonia, the shift is, the leukocytosis is because of the pneumonia, and we start antibiotics. This is a mistake. The antibiotics needs to be evaluated in 48 to 72 hours with a few parameters to start with. Urea, creatinine, sodium, potassium, and glucose was normal. She was brought to ICU, where the Glasgow the neurological examination was a Glasgow 7. And it's usual also to request a CT scan at that time, but this is not need. Actually, when you think about transport the victim from the ICU or from an emergency department to the CT scan, it gives you some possibility of mistakes on the aortotracheal tube, on ventilation, not pay attention for different things. So to do a CT scan of the skull, it's very important that you have some basic history that she may had a trauma over the drowning event. She was sedated, narcotic was introduced, muscle relaxant was started for 48 hours. We should keep her very rest until her lungs recover and had produced more surfactant and be able to ventilate without such effort. The follow-up went very well in mechanical prosthesis, little secretion, blood glasses with improvement in metabolic acidosis and respond to the reduce of respiratory rate and tidal volume. In tidal volume, we decrease the tidal volume. It's usual as the airway pressure it's very high. It's usual to make this mistake to use more volume to deal with this pressure, but this is a mistake. Within 24 hours, the medical staff proposed to winning the ventilator and intubation, but it was contraindicated by an expert on drowning. What is usually seen by those critical patients is that they get better very fast. Sometimes in 12 or 24 hours, the oxygenation is very good. and someone say, oh, let's winning the patient. And this is an error because the surfactant is not replaced yet. The V key perfusion is very, very low. So when you pull out the PEEP, you're gonna throw the patient to a very low lung compliance, and you will have much more time to replace the 24 hours before than if you keep more hours on the ventilator. In 72 hours, the weaning process was started and the children was discharged without sequela after 8 days. So we can give you a pause because I think it's too much. I have a few things to say that we can remember that, but let's give you a pause and ask you if you have any questions for that first part. It's a good time to do it.
Is there any question? But I have a question. You say that it is wrong to start the weaning too fast. So your suggestion is to how long should you wait until start the weaning?
Yeah, at the moment you decide that the patient needs a mechanical ventilation, I usually make at least 48 hours. Usually the best way is after 72 hours because it's the time for replace the surfactant lost by the wash out of the water.
And the oxygenation should be keep for all the time high, or reduce?
Yeah, no, you can use inspire fraction as low as you can. Also, the PEEP you can decrease to 5 and keep it in 5 until 48 to 72 hours, and then the weaning start.
And is there a target peripheral oxygen saturation to keep, or because at the beginning you say that at the beginning we need to have 100, the maximum of peripheral oxygen saturation at the beginning, and then should we keep the maximum or should we have a lower target?
Yeah, I wish you should have lower target because if both hypoxia and hyperoxia is bad for the brain. So as soon as you get on the emergency department and you get a good mechanical ventilation, you should titrate to get lower, as much as lower as you can, to give at least 24, 23 to 24% of saturation, oxygen saturation.
Thank you very much. For me, it's okay. I don't know if is there any other question on this part. I think we can.
Let's go ahead. So the rest part is it's a overview of drowning. So our planet, our Earth planet, should call planet water because it's 75% of water, and as long as we leave, more drowning will happen, more sports, aquatic sports, more prospection of oil, etc. I will talk about a little from our country, Brazil. We have a huge coast, a huge possibility of drownings, a very good water temperature all the times, and in the world, 10 persons drown and 1 dies every minute. In Brazil, 16 persons die by drowning every day. Drowning is the leading cause of death from 1 to 4, second 5 to 9, third 10 to 14, and fourth 15 to 24 years old. This is among every other cause. So drowning for us is something very worrying and very in the need to take action, a lot of actions. We know that male drowns and die much more often than female. You see, from 20 to 24 years old, male dies 15 times more than females. That's amazing. How we think we are strong and we are not. So this is a map of Brazil. Can you see my arrow here? You can see okay. This is all inland. There is no water, there is no sea around here. The sea comes from, the sea comes from here until here. And you can see that the worst scenario for drowning, the risky one, is at the north and at the center of Brazil. So our problem is not exactly the coast. The coast are very well guarded by lifeguards. Our problem is rivers, dams, ponds, floods. 75% of the drowning deaths in Brazil are in rivers, dams, and ponds and floods, and not exactly at the coast. So why is that? It's because lifeguard is all over the coast, and those places, inland places, there's no lifeguard, there's no education to tell people, don't do that, do that. So it's very important for us, the educate the population. We expend $15,000 US for each drowning death in Brazil. This comes to spend at $300 million US each year on drowning death in Brazil. We still hope that a part of it will be invested in prevention. And that's how we see drowning. When you see how can I treat drowning? This is the most benefit of treating drowning is prevention. It's how we see as health professionals. Prevention is much more important but the layperson sees otherwise. When you say that you're gonna teach or you're gonna give a class about drowning, they thought about providing care, BLS, ALS. But the very important thing is prevention. How? And we can show you that in this paper research we published a few years ago that shows in a beach, 5 summers season, in one single beach of 4 kilometers, the lifeguard made 1,563,000 intervention. 99.9% was prevention. Rescue was 0.1%, and provide care by a health professional was 0.02%, showing how important it is for yourself as a medical residence or emergencies to spread the tips of prevention to yourself, to the others, to your family, and everybody who is around you. Well, the death in Brazil is still going down. This is a graphic that shows death by 100,000 population. Although all these numbers is frightening, we see only 6% of all problem. This is the drowning timeline, another paper, another research we made with the international authors that show all the timeline of drowning. What is a pre-event, what is an event, and what is a post-event. This works very well for every trauma, for car accident, for a burning, for demolition, any accident, any trauma, this works very well. to think about the whole problem, not seeing just the hospitalization and post-hospitalization, the tip of the iceberg. This is 1771, where the first guideline was made to everyone and was based on drowning. And it says, warm the victim and remove wet clothing. We're still doing that. Aspirate the water by positioning the victim with the head lower than the feet. We stopped doing that 30 years ago. Stimulate the victim with rectal or oral tobacco smoke. Thanks to God, we actually stopped to do that a few years ago. Use the mouth-to-mouth resuscitation method. We still doing mouth-to-mouth resuscitation at the pre-hospital, and bleeding, we stopped to do that. The same story happens in Rio de Janeiro, where I live, in Brazil, where we have all over the place, we have water to have drownings. This is the first lifeguard tower in Copacabana Beach. We are not sure how the lifeguard get down to make the rescue, but probably he has some way to do it. This is the first ambulance to do the pre-hospital attendance, and it was created to attend drowning situation, 1930. And this is a Schaefer maneuver, where I'm positive that even Giorgio never heard about this one. This is how they do the CPR before 1960, when they understand that they should do it by chest compression and ventilation. And this is a very usual situation here for us. And this is a situation in Copacabana Beach. Your Pope, they came from Italy to visit us and make a very big ceremony. And it was it was an attendance of 2.5 million people on a 4 kilometer of beach, 1.5 meter waves, 145 rescue was made, 130 lifeguard was on duty, 3 ambulance, 2 helicopters, and 1 drowning resuscitation center was on. We had 37 medical attendees and 0 deaths. But it was very different from this other situation. 2 years ago, our Rio de Janeiro holiday city, where the people attending was almost the same, 3 million people on the beach, 1 meter waves, but 2,000 rescues was recorded in 1 day. 560 lifeguards working, more 180 volunteers, 5 ambulances, 2 helicopters, and 2 drowning resuscitation centers all over working together to fight this disaster. 135 medical attendance was made and 4 deaths by drowning in 1 single day. What is the difference between this one and this one? It's very clear. Drowning is composed by 2 main factors. One is the scenario risky, or the risk that scenario has anytime, any moment. The other is the swimming competence of the people who is getting into the risky environment. So if you see before, people who attend the Pope ceremony was people that had the focus on the Pope. They were dressed. They did not drink alcohol. behave. It's much more safe than this one, which they went to the beach to make party, to drink alcohol, to get in the water. So behavior is so important when you are talking about drowning. So drowning is the process of experience respiratory impairment from submersion, immersion in liquid. So there is only need that your face is in the water and you aspirate water and you are drowning. We differ from rescue, which is a person in water distress without coughing and with normal pulmonary auscultation. Drowning has primary cause, those that didn't know the risk or thought that they are over capacity or over competence for fight the risk and they drown, or can be secondary to some precipitant disease, like they use alcohol, they have a convulsive crisis, they had a trauma or a heart attack, something that suddenly decrease the water competence of this person and make his or her very vulnerable to drowning situation. So the process of drowning is we fight a little to not get the airways in the water, but the first aspiration occurs, and this from now this point you're not more a rescue, you're a drowning person, and then as much you are aspirating water, your severity is getting worse. So what does it mean? That if you get 10 seconds in the water, you're gonna aspirate a little amount, but if you get 15, 20, 30 seconds, you are going to aspirate more water. This will affect your exchange oxygenation, and this will lead to a respiratory arrest. And then in a few seconds or a few minutes, we're gonna lead to cardiac arrest. This is the whole process. So it's very important when you receive a patient at the emergency, understand how is the severity of this patient, which will come up with the appropriate treatment and knows how the prognosis will be for that patient. So hypoxia is the most affecting factor that we have to avoid. And this is a grade 2 of drowning. You can see a little hypertransparency here from the water aspirate. And this is a grade 3, where a more amount of aspirate water, and you can see it's a more hypertransparency. Don't fool yourself. For this one X-ray, and it's only need a half a cup of water. You only need a half of cup of water, 1 to 3 ml per kilogram of body weight to give you that severity of drowning. And this is a case from grade 3 to over grade 4, 5, and 6. They all need ICU treatment. So male drowns more, single drowns more indeed. Almost half percent of the drowning person usually think they are swimmers, but they are not good one for fight their risk. And what is important also for you emergencies is almost all fed 3 hours before the drowning happens. So they will be vomiting, they will be some food at the mouth, and you have to clean this up to not give any complication. And this is the important figure that we have in drowning. This is a work we done in 2014 in resuscitation, and this will be published in American Heart Association guideline this year. And this is 5 links, 1 chain, and we will be remembering this in the next slides. The first one is to prevent drowning. So we have, as Sobrasa in Brazil, we have a lot of prevention programs for kids, for surfers, for health professionals, for swimming teachers. And so there's a menu of programs that we make available. We use a lot of cartoons, videos, very short. We use a lot of comic books to teach children. And we have already covered that, how to recognize a drowning event. So be trained when you go to the beach, when you go to the pool, take a look of the people swimming around and see how someone have very good competence and others have very struggle a lot to move from point A to point B. Those are the drowning risks. And this also we cover how to use the flotation to help. And when you decide to start basic life support, it's important to know that we recommend that you start basic life support still in the water. You know that the respiratory arrest take place first and then cardiac arrest. So if you are able to do in-water resuscitation still in the water, you can recover the victim still breathing from the water. And this gives you 3 times more possibility of a good outcome. Of course, this is not for all of us. This needs to be trained. If you are in the shallow place, you can stand up and do mouth to mouth. But if you are in deep place, you need to have a professional flotation to be able to do that. And when you are pulling out the victim from water, of course, if you are in the boat, it's some different from the beach and different from the pool. And but it's important that you keep the vomit, the alimentation, the food on the stomach. Every maneuver that you're gonna do right now, ventilation, transportation, cardiac chest compression, you should consider avoiding vomitation. So let's go step by step. It's very short. The first one is to position the drowning parallel to the water edge. The trunk needs to be at the same level of the head. Check for an answer. Are you listening to me? If so, she is alive. Evaluate the need to call for extra help, lateral recover position, and wait. If not, ask someone to call for help. As simple as possible, open the airways. We just only advise to clean the mouth if you get some visible foreign body or debris on your view. Doesn't pay attention too much to clean the airways at this point. Check for ventilation. See, hear, and feel for ventilation. If no ventilation, or if you are in doubt, give 5 mouth-to-mouth ventilation. This is all in U.O.C, in resuscitation guideline by U.O.C. and then check for circulation. There is no pulse for basic life support. There's no pulse more. You check, how you check for circulation? After you give ventilation, if there is no response, you assume that is a cardiac arrest and start to do 30 chest compression. For 1 to 8 years old, use only one hand. And this is a summary of the drowning severity. At first, you put the head and trunk at the same level. Do not attempt to withdraw water from the lungs or airways. Check for answer. Are you listening? If the answer is no, open the airways, feel, listen, and hear for breathing. If no ventilation, you give 5 ventilation and check for circulation. If there is no signs of circulation, this is a grade 6, and see that you are already doing something. You're not classifying the severity for doing something. You are doing immediately something. If there is sign of circulation, it's just a grade 5, is a respiratory arrest. In the other arm of the algorithm, you say, if you ask for an answer and they are listening to you, respond to you in any verbal or modal movimentation, you check for cough and pulmonary auscultation. If there is absent, there is a rescue only. If there is cough without foam, is a grade 1. If there is small pulmonary crackles, it's grade 2. And if there is acute pulmonary edema, you need to ask yourself if there is hypotension or shock. If there is no hypotension or shock, grade 3. If there is hypotension or shock, it's grade 5. For each grade of severity, which is very easy, I can recommend you to give a read on CHEST 2020. It's a paper we published, a review on drowning, and there is the whole algorithm and what to do in each level of drowning severity. It all involves calling for an ambulance or a helicopter, and sometimes you are on the beach and you are the medical doctor, you do not have the backup of your hospital. Everyone knows that you are a medical doctor, you're gonna have to act, and you should do it without any equipment, and that's the real life. So what I think is the most important question. The first one is, what are the most impacted intervention on drowning? What is the most frequent place for a health professional to attend a drowning person? We saw that. I mean, it's on your leisure moment. You are in the pool, you are at your house, where you are at the beach, you are surfing, you are kite surfing, you are doing something, and everyone knows that you are a medical doctor and you will need to act. What are the drowning definition? It's very important that you understand when is a rescue, a trouble, a person who gets troubles in the water, and when is a pathology of drowning. What are the 2 factors most important to determine the drowning severity, which we saw that is the time to rescue and the amount of the water aspirate. So someone can be in the water for 4 hours, and if he doesn't aspirate any water, is still a rescue, is not a pathology of drowning. And what are the worst elements to treat a drowning? So we saw this as a prevention. And for our ending, what is the biggest challenge for prevention? And you're gonna see the next one. Sorry. Why this video is, of course, is a simulation. Why this video is important? There is a barrier between what we know, all of our tips on prevention, all our education material, and the guy or the person who is possibly being a drowning person. We should be able to give those material, to give those tips for them, but there is a barrier. The barrier is you should believe that sometimes in your life you're gonna be a drowning person. And this is a real one. Even in a pool, even swimming, even surfing, even in a boating or fishing, you will be sometimes in your life, you're gonna be in trouble. So it's very important that you know how to get out of the trouble. It's very important to know that you know how to help someone in trouble. And this involves the youngest and the oldest people to avoid something like that. That is a child drowning in a pool, a very small pool, and with a very severity sequela of vegetative state forever. So this is what we are trying to avoid. Thank you, George.
Thank you very much. Thank you very much. Yes. Are there any questions? I have some questions in Matteo Paganini. There's Matteo, do you want to
yes,
speak?
So first, thank you very much for this brilliant presentation. It's been very, very clear. Also, thanks to the video that's been pretty clear and impressive. So my first question regards the in-water breathing rescue, because it's a controversial theme. So what's your advice when to, it's a technical aspect, okay, but when to use them, for example, while waiting for a motorboat to rescue us from very, very distant from the beach, for example, instead of swimming if you are near the beach?
Yeah, yesterday, thank you for your question, Paganini. Yesterday, I was in a meeting with American Heart Association, and it took 2 hours for us discussing just your question. We still don't have a whole answer, and I'm be very clear. I made a research in 2004 about how benefit is that you ventilate the victim as soon as possible, and if this is safe for the rescuer, this should be done in the water. So the first priority is, are you safe to do that? Okay, so you go ahead. Are you training to do that? So you go ahead. So if you are in shallow water, you can stand up and do it, the ventilation. And you should do up to 10, at most 10 ventilation in the water. If you cannot stand up, you need to have equipment with you, because it's not easy to float and ventilation in the water. So, but it's very often, and we have many anecdotal cases that shows that the surfer is someone that it's very benefit to do that, because they always see the drowning person very first at the water. The swimming teachers, everyone who is involved in teach or doing aquatic sport should be training and doing that, because this is a lifesaver. And the reason is that as the respiratory arrest stops first, and you have a very short window from respiratory arrest to cardiac arrest. And this happens in another situation also, not only drowning. It happens in trauma, hypothermia, children, intoxication, some specific cardiac arrest of respiratory origin. Did I make myself clear or not?
Absolutely. So being a controversial theme, so we are expecting from American Art some clarifications thanks to you. May I ask a second question? Okay. Can you tell us some basic differences between saltwater, freshwater, pool water, and maybe bust some myths that are going around between these differences? So the real differences that impact the outcome of the patient, the acute one and maybe the more delayed one outcome.
Very good question also. It's a very wordy question when you receive a patient at the ER, that the question is usually is salt or fresh water. But this actually doesn't mean anything, because the treatment is the same, the prognosis is the same, so you don't have to worry about if it's salt or fresh water or brackish water. The important question here is if it's in a polluted water. So, for example, if there is a water that is 10 elevate to more than 20 colonies CFU by ml, this is actually a primary possibility of pneumonia. In those cases, you start antibiotics immediately. So the importance of the quality of the water is by the possibility that can cause you a pneumonia immediately. I have much more things to say, but I don't want to bother you guys.
Thank you so much.
You're welcome.
But and so the antibiotic prophylaxis is not correct, right? Exactly. Not correct. Exactly. Just after, and it is normal that in the first hour there is increase, you say, of white blood count and of CRP, yes? And so we have to wait until 2 or 3 days to start antibiotics. Is it correct?
Yeah, exactly. It's like that. You only start antibiotics if there is an immunodepressed patient where you have the colony of the water over or between 10.6 to 10.20, and or if there's anyone and you that drown in a water over 10.20, so you give immediately antibiotic, which is a very rare situation. Usually water is much below 10.3 or 10.2 of pollution of coliforms.
And you show that most of the deaths are in where there is no sea, okay? But and what about the rescue? I mean, are there more near drowning, but people that are that then do not die in the near the sea? Or...
Okay, I got it. what happens is at the coast of Brazil, and this happens all over the world, where the place where you put the lifeguard is usually the place that has more attendance. The tourist one, the beautiful beaches on the Mediterranean Italian coast, there is always lifeguard there. But if you go to a river or a waterfall or some or a lake, there is no one usually guard than these places. So at the coast, there's much more rescues done and much lower death. Different from the inland, which has too short or too small occurrence of rescues and high occurrence of dying. We have a estimative of that the death occur in places occur 60 times more often in places where there is no lifeguard. The risk that you go to a place that there is no lifeguard is 60 times more risky. Understand? So you are by yourself.
And the other thing is, in a rescue patient, imagine that a patient comes to our emergency department for drowning, but now he's okay. Do you think that we have to observe the patient, or when can we discharge the patient? And the other question is, when the patient is not intubated, what shall we do? Do you think is good to use, for example, non-invasive ventilation, or do we have to do something, or just observe the patient?
Yeah, what happens is that in 1972, we got this problem that we have a medical team at the beach supporting the lifeguards. And lifeguards call and say, I need the ambulance. And they need to say how severity is the patient. So from that on, we create the classification of drowning, which can be used very easy for lifeguards or layperson until ICU. So what I advise you is to post. I can send you later. You need to post the algorithm, and they will help you out to treat, prognosis, and how to treat them. So answering your question, for rescue, you can release. For grade 1, you can release until there is no associated pathology. Grade 2, you have to observe at least 6 to 8 hours at emergency room with a small catheter of oxygen, 5 liters. It's usually enough. Grade 3 and 4 is usually you have to intubate, put in a mechanical ventilation, goes to ICU and rest. And grade 5 and 6 usually is treatment similar to grade 3 and 4. So they need to be observed. Sometimes it's very impressive, because I had attending some patient that was in respiratory arrest or was in cardiac arrest, but they are so quickly recovered that when I get there with my ambulance or my helicopter, the person is standing up and say, I want to go home. But this patient wasn't in CPR, in cardiopulmonary arrest. So they need to be observed. They can evolve to pericardial hemorrhage or pneumothorax or some ribs fracture. They need to take a look for at least 24 hours at the emergency room to make sure they are okay to be released.
Thank you very much. It was very clear. Is there any other question? I really thank you very much, and now I understand why you did so many review on chest and New England and so on, and so many works. I think that it was very, very important for us to listen your presentation. Thank you again. And if you are going to come to Italy, we will show our beach so that you can save some life there.
That's great, Giorgio. Thank you very much. And you are all welcome to Brazil.
Thank you very much. Thank you. Bye.
Bye.
Thank you.